Welcome to podcast Birth Vibe by Rainbow Hospitals. I'm Dr. Shruthi Reddy, working as a consultant gynecologist at Rainbow Hospital, Banjara Hills. Most of the pregnancies, they progress smoothly and it is always associated with joy and celebrations. But in some women, it comes with a lot of uncertainty because of complications related to the pregnancy. Today, we are going to talk about placenta previa and adherent placenta and clarify those doubts generally what a patient has so that it is clear. With awareness they can actually handle these pregnancies in a smooth manner. Placenta is an organ which takes blood from the mother and it gives to the baby and gives nutrition to the baby. When the placenta is attached in the lower part of the uterus, it is called placenta previa. Generally, the placenta is attached in the upper segment of the uterus and it gets detached after the baby is born. So, there is a decrease in the blood loss in the mother. When the placenta is attached to the lower part of the uterus at the entrance of the womb, it is called placenta previa. And when it is not getting detached after the delivery, it is called adherent placenta. When these two conditions are there, which is placenta previa and adherent placenta, there is an estimated that blood loss is going to be massive and there can be a sudden blood loss in a short period of time, which can lead to low blood pressures and collapse in the mother, and also can lead to premature delivery, and it is not safe for the baby. But it is a complicated case, but it is can we can ensure the safety of these kind of pregnancies by following certain planning and having an extra care and a multidisciplinary team. Today we have Dr. Niraj, who is our surgeon doing these cases in Rainbow Hospitals. We work as a team, and he is one of our surgeon who is doing these cases. Welcome, Dr. Niraj.
Yes, thank you, Dr. Shruti.
So, as you know, when we diagnose there is a placenta previa and adherent placenta, which is diagnosed on the MRI scan, what comes to your mind when you have to handle these cases?
Well, first of all, thank you for taking up this topic, which is quite a sensitive area because women who have been diagnosed with either low-lying placenta or someone who has an adherent placenta, as you mentioned in your introductory remarks, that creates a panic because of what they have read or what they have seen or what people have told about that particular condition. So it's very good that you have taken up this topic. Thank you for that, and thank you for having me here. It's a pleasure being here. Now, to answer your question, what comes to my mind first thing, as a gynecologist, as a gynecological surgeon, first thing that comes to my mind is these things, that how worried or how panicky the couple is, how worried the mother is, because I'm sure, will have heard lots of stories from all the social media and friend circle and so on. So, first of all, my first approach would be to try and reassure her that this is not something which is very unusual. Yes, it's not very common, but it's also not very unusual. We've done these kind of situations, we've dealt with these situations successfully over many years. So, first of all, the first job is to keep this couple and the lady reassured that she is in safe place. We, as you know, we have been working as a team for a very long time and we've given excellent outcomes almost always. So that is first thing. Second is then looking at the severity of the condition which I'm looking at, taking the whole picture into mind and being prepared. Essentially, we have to involve our team at a particular stage of pregnancy, not from the very beginning, but when we are planning her delivery date and mode of delivery, we need to involve our team. That is what will be in my mind as to at what stage shall I get my team involved. And there will be people who she'll have to go and see, people meaning my colleagues from various departments, including, for example, anesthetist. That's just one thing which comes to my mind, first thing. So that kind of planning will be behind my back, in my mind,
So, when you
where
see
I will.
these patients in the OPD, you would like them to see the anesthetist before the surgery is
Yes, of
planned.
course. Yeah, yeah. It's very important because it's not only the gynecologist or the obstetrician doing the delivery. They are equally important component, important part of the team managing this particular patient, this particular pregnant lady when it comes to delivering her. So yes, they will be on top of my mind, along with neonatologists, the pediatricians, for example, those who look after the babies after the baby is born, because we don't know what stage of pregnancy we may have to deliver her. So that also becomes an important thing for us to get them in the loop.
So, we as surgeon, we should be prepared to deliver them as and when there is a need, and the patient also has to be prepared to come if there is sudden blood loss, so that we can manage these cases in a better way. So when you have to manage these cases, what is your checklist when you have to plan a surgery for these cases?
Now, there are two things which you mentioned in the beginning. There's one condition called placenta previa, the other one is adherent placenta. When you talk about placenta previa, it simply means that the placenta, which is should be in the upper part of the womb, upper part of the uterus, instead of being in the upper part, it's in the lower part of the uterus. Now, there are several grades. I don't think we need to go into those grades, but the severe most form of this placenta previa is where the baby's path of normal birth canal is blocked because the whole bulk of placenta is obstructing or coming in way. So in those situations, we call it as the severe or the stage 4 placenta previa or major degree placenta previa, where it will have to be a cesarean section. It cannot be a normal delivery. And those are the situations where we should be prepared as a team to handle major blood loss in a very short time. So it's a very brisk blood loss and in a very short time. So the whole team has to be geared up to deal with this situation, and the couple also need to be reassured that this may happen, in which case they don't need to panic. We'll do the right things at the right time.
So you basically prepare them for the blood loss. So you make sure that blood products are available, and then improve her hemoglobin before the surgery, and then you plan it. So would you like to see the patient in an emergency situation, or you always want to see manage these cases in a very planned?
Say it is never ideal. We wish we live in an ideal world, but it is never, or it is not always an ideal world. There have been so many situations. You have been involved, I have been involved, where someone has referred, one of our colleagues from outside Rainbow Group has sent patient because she's bleeding or she's not available or they're not equipped to deal with these kind of situations. They just sent randomly at some random time, maybe 2 a.m. also we have come and dealt with this, where we have seen the patient the first time, where there was no time to interact with them or to reassure them or to take into confidence. But we have dealt with those emergencies and we will continue to do that. So yes, in the ideal world, I would like to see them before. I would like to see them throughout their pregnancy, right from the time that they conceive, so that we are better equipped, better geared up. There's a rapport between the doctor and the patient developed, and they know that they are in safe hands as well, in the safe place, in the safe hospital. That's very important. So yes, to answer your question, would I want to see them? Yes. Does it happen always? Answer is no.
Yeah. So basically, you would like to do it as in a planned cesarean rather than an emergency. So, as you said, when the placenta previa is there, there is no chance that the patient can have a normal delivery. It has to be a cesarean section. So, the next question is, how is it different from a routine cesarean section in these cases?
Now, one thing I think we may have to tell our audience, that placenta previa automatically does not always mean a cesarean section. In the minor degrees of placenta previa, where the placenta just dips in the lower half of the uterus, but does not really come in way, or once the baby's head, for example, goes past the placental edge, we say, then normal delivery is possible in the minor most forms of placenta previa. So technically, we may classify it as placenta previa, but it does not come in the baby's passage in a big way. So we
So
can.
today's our podcast is based on the major
Sure.
placenta previa
So
only. It is
coming
the
back to that
major
point.
problem. Yeah.
Sure. So coming back to that, now there are two or three things which we have to consider. One, where is the placenta in terms of, although it is low lying, is it, which is it anterior, which means is it more closer to our incision skin, or is it behind the baby's head, or behind or away from the area where I would be cutting open the womb to deliver the baby. So if it is in my way of doing a cesarean section, then that is a little more riskier procedure because I have to cut through the placenta, or there's another technique where I can go below the placenta and deliver the baby. But that is not the most ideal situation. But yes, one of the things which I will have to know is whether the placenta is in the anterior segment, we say, which is closer to the skin, or is it away from the skin, which is relatively easy. Both will have the risk of bleeding, but the one which is closer to me is going to bleed more, and it may be a little more challenging to deliver the baby because of the gush of blood which also comes out with it. So those are the things, and both in these situations I'm expecting that the placenta will be covering the cervix, which is the birth passage, which is the entrance to the uterus. So that is where risk of bleeding also is more. So those are the things in my mind when I'm doing. So compared to routine cesarean section, of course it is going to be very different, because in the routine cesarean section I'm not going to get this kind of obstruction in delivering the baby. Here the obstruction is the placenta, it is coming in way. In a normal cesarean section, that is not the case. Second, bleeding, which is going to be significant in placenta previa, which will not be in a normally placed placenta.
So, Dr. Neeraj, this placenta previa is of two types, as you know, minor and major, where major we expect more problems. So, in these kind of cases, patients might ask sometimes that is normal delivery possible? What do you say?
In most situations where the placenta is major, which is low lying and which is obstructing the way of the birth canal, in those situations, yes, it is going to be cesarean section.
So, how is it different from a routine cesarean section?
What makes it different is the amount of blood loss which we encounter at the time of delivery of the baby. That is what, and also once the baby is delivered, after that also there is a significant risk of bleeding. In a very short time, there can be a very significant blood loss. That is what makes it different than the normal cesarean section.
So, how do you manage these cases when compared to your regular cases?
Now, this is where the teamwork comes into play, because all the team is aware that this is the step where they should be getting involved, where the blood loss is going to be more. So, our anesthetist should be all on the same page. They should immediately start resuscitating the fluid and giving enough replacement of the blood loss which which the mother is going to have. And that replacement can be in the form of fluids, which we all probably know, and also blood components or blood, depending on the situation which they think right and which we as a team agree with beforehand. This is where the pre-planning comes in. So that is where the pre-planning goes in, and the patient care also needs special attention from the anesthetist and the obstetrician together.
So generally, we see a little bit of amount of blood loss in cesarean section. How is it different in these cases?
Normally, if you go by books, we would say, yeah, blood loss of around 500 ml to 1 liter is normal for a cesarean section, which is not low-lying placenta or placenta previa. But in women who have placenta previa, this blood loss can be significantly high. When I'm saying significantly high, it can be around 1.5 liters, 2 liters, or even more, depending on how briskly you and your team is able to control or stop the bleeding. The blood loss will keep continuing. So that is where the amount of blood loss is different than the normal cesarean
So,
section.
what is the extra procedures? Do you do any extra type of surgical techniques are there to control this kind of bleeding in these cases?
Yes. Uh, Surgically, there are certain things which we do. One of them is we call uterine artery ligation, which is the blood supply to the uterus. The whole purpose is to try and minimize or reduce the blood loss to the blood supply to the uterus. So the blood loss is going to be less. So one of them is uterine artery ligation, which most of the times doesn't really give the desired outcome. Then we go to or many a times we directly go for internal iliac ligation, which is another vessel which supplies to the pelvic organs and primarily to the uterus. So that is another surgical step which we do, and this gives excellent results. Almost always we've been able to manage and control the blood loss once we've done the internal iliac ligation. If we think that step is not needed, then there is something called a balloon tamponade, wherein there are specially designed balloons which we keep inside the uterus, and those balloons are distended with fluid. So essentially what's happening is, from a raw area of blood loss or bleeders or bleeding vessels, we put a balloon tamponade on it. So we put pressure on those open blood vessels to stop the bleeding, and those blood vessels then clot and the bleeding is significantly controlled. So these are the various techniques which we do. In rare situations, we may even have to do aortic compression. Aorta, most of the audience may have heard, that's the main
Main
blood
blood
vessel
vessel which goes.
from the heart which comes out. Even that may need to be compressed, or pressure may have to be put on it to control the blood loss until some definitive steps are taken. We may have to do that. So there are various techniques which we are well versed with, which we've been doing for years, and those are the things we
So
deploy.
basically, your swift surgical techniques will help the patient to decrease the blood loss and maintain her blood pressures. So, despite we had seen, as you had seen, we had seen many cases of placenta previa and adherent placenta where the blood loss was so bad that despite doing all these procedures, there is a chance that the blood loss is going to be more. So, in these cases, what extra techniques you can think of
See,
doing the saving
in
the
yeah,
mother?
in these situations where everything else is not working, then we have to go for the final thing, which is removing the uterus. So we will have to remove the uterus, remove the womb, and stop the bleeding, and that is almost always going to be the final answer. But we are reluctant to take that step unless everything else has failed. So yes, to answer your question, the final step will be removing the uterus.
So, though sometimes, very rarely, we may have to remove the uterus in cases of adherent placenta where the blood loss is not getting under control with the other surgical techniques. We may have to proceed for hysterectomy, but that is also can be safely done, and these things are have to be done to save the mother. So basically, the baby will not be affected that much, but the mother is in danger when these things are not taken care at the right time. So these cases after the surgery, so what extra care? Like generally after the surgery, we keep the patient for observation for 2 hours and shift the patient to the ward. So what extra care do you recommend for these cases post delivery?
Now, there are two things. One, if in women who have placenta previa, we have controlled the bleeding and the uterus is retained, or in these women, we have put balloon, for example, to stop the blood loss. Those are the women who, for them, the next 24 hours is going to be very crucial because the bleeding can happen again at any point. So we can't just treat them like any other cesarean section and send them to room after 2 to 3 hours. There were situations where we may have to keep the patient in the recovery under observation, close observation for almost 24 hours. And once we sure that she's her vitals, we say, which means the blood pressure, pulse, and her general condition is very nicely stable and under control, then we remove the balloon in stepwise fashion or directly, and then we shift them to room. So we are in no rush, no hurry to send these patients to room like we would for those who have a normal
So
cesarean section.
basically, these patients require monitoring for the
More
next
close
24
observation.
hours
Yes.
in the ICU care.
Yes.
That will be the ideal way.
Yes.
So, as you have mentioned, so many complications which can be dealt in a safe manner. Pre-operatively, what care you will explain to the patient? So, what to expect when the patient comes to you? What is the counseling you're going to do for the patient to know what other procedures can be done to this patient?
I think we'll keep it simple because the more information you give, the more panicky they become. From their perspective, from our perspective, what is important is we take them to term, which means by 8th to 9th month of pregnancy, around 36, 37 weeks, they should be in good general health. If they have diabetes, for example, it is well controlled. If they have blood pressure, it is well controlled, and so on. Most important, hemoglobin levels, her iron levels should be good. So we should make sure that she starts her pregnancy and continues her hemoglobin levels at a very good range. So she has more capacity to lose blood if it comes to that. So someone I'm operating at, say, 11 grams percent of hemoglobin, as opposed to someone who's 8 grams. So this lady who's 8 grams has less reserves, so it's more likely that she'll get compensated more quickly. Therefore, those are the things which I'll talk to them about. And of course, I'll talk to them about the need for blood transfusion, and also as we just discussed earlier, about need for hysterectomy if the blood loss is that significant. So those are the things by and large, and also post operatively what she should expect. We'll have counseled about the maximum possibility of retaining her uterus, but if need be to save her life, in the interest of her life, we may have to remove the uterus. These are the things which I'll normally tell them. And post operatively, after the surgery, what is the care she would expect, and what kind of recovery she is looking at. Those are the things which I'll make her ready from. I won't get into technical details because they won't understand. The more information you give, the more she's going to get panicky.
So basically, when this kind of a diagnosis is made, the patient sometimes come and ask, "Madam, can we deliver in our like hometown?" So what do you suggest?
I mean, as clinicians, as gynecologists, as obstetrician, it is my duty to explain her the severity of the problem. Now, if she believes that her hometown, wherever she comes from, it can be a district place, it can be another city. If there are hospitals who are geared up to do these kind of surgeries and deal with this, it's up to her. But from our perspective, I would suggest her to be in a hospital where there is good experience in dealing and handling with these situations, and more importantly, having the blood bank in the same place, having anesthetic team who are very well experienced to handle sudden blood loss, because not everywhere you'll have this kind of experience to do it. So they have to make this decision very carefully as to where they want to deliver. But my emphasis would be to deliver in a place where there's a lot of multidisciplinary team
So
experience.
basically, it is not one
It
surgeon who
is
is
not one
going to
surgeon.
handle the case.
Absolutely,
It
yes.
has to be a
Yes.
teamwork, including the anesthetist,
Yes.
availability of the blood products,
Yes.
and then not even one surgeon. It has to be a team
Yes.
who can handle that
True. Yeah.
surgical techniques also
Yeah,
swiftly.
and as we mentioned earlier, neonatologist also is important,
Yes.
because at some point she may suddenly
Yes.
start bleeding at 32 weeks or 30
Yeah.
weeks of pregnancy, and we may have to deliver her at that stage. Does her hometown allow her to take all these risks? That's up to her. I can't tell her don't go, but
If
if
at all
yeah,
they have all these facilities with the teamwork, then it is their wish. But
is there
otherwise,
their
generally
wish?
the recommendation is to be delivered in
Yeah.
a tertiary center where
Yes.
all the facilities are
And the
available,
experience, yes.
and the experience
Facilities should match
definitely.
with the experience as well. You may have all the facilities, but you don't have the experience, you can't do it. So in a center like ours, for example, we all have been working together. We know how equipped we are at any point of day in time. We just have protocols laid out. Anybody comes with this kind of picture, we know what to do. And all the team, it's not only you and me, it's also those
Yes, it is the
nurses,
team, the
it's also the
protocol.
OT assistants, it's also the non-medical staff who are geared up to handle these situations. That's important. It's not only the doctors, it's also about the nurses, it's also about the OT technicians, for example, who need to be geared up, including the nurses in the post-operative recovery ward. So the care doesn't finish once the baby is delivered
Yes.
and the uterus is closed. The care is finished once the patient goes back home and doesn't come back with problems.
So, thank you, Dr. Neeraj, for enlightening us about the surgical techniques and then the care which we have to take during the surgery. So, basically, this placenta previa and adherent placenta is associated with sudden massive blood loss in a very short span of time, which needs an extra care from the surgical team. And it has to be in a multidisciplinary team to get good outcomes out of these problems. Whenever the patient is diagnosed with placenta previa and adherent placenta, do not get panic about it, but at the same time you should understand that it needs extra care, and absolutely safety can be ensured with the proper planning and a meticulous surgical techniques along with the anesthesia inputs.
Thank you, Dr. Shruti, for having me on the show and allowing me to share my thoughts and my experience with you. It's been a pleasure. Thank you.
Thank you, Dr. Neeraj. And stay tuned to Birth Vibe by Rainbow Hospitals for further information. Any kind of these problems, you can always get in tune with this podcast so that you can be aware of the problems and can clarify certain doubts. Thank you once again.